Hello and welcome to Good Drugs. I'm Dr. Michael Fiedler, and I'm a believer that we all need potions, elixirs, magic pills to get us through this thing called life, and it's just up to us to find good ones. So, with that in mind, I had this idea to create a podcast that focuses on drugs I have come across over the years that I think are cool, that do something or behave in a way or function in a way that is noteworthy. And I wanted to use this as a platform to talk about them and share my thoughts because I think that they're entertaining as well as sort of forward thinking into where we're headed in various aspects of various aspects of medicine. And so the drug I wanted to get us kicked off with is called Atuzaginstat, or COR388, and it's made by a company called Cortexime. Uh, it is being investigated for the use in Alzheimer's, and Alzheimer's is obviously a tricky disorder out there. It's a leading cause of dementia, which is essentially sort of a breakdown of cognitive ability, executive function, speech, memory. It's really a whole broad host of things that happen, and I think that the feelings around it are still very grave because I'm sure we've all known somebody that sort of succumbed to it. But in terms of how to treat it, maybe we're beginning to see some optimism. There have been some new treatment modalities, or one in particular that looks like it's approaching FDA approval. It's not a slam dunk yet, but it's close. And that drug is called aducanumab, which is a tough one, but it's had a to say, but it's a it is a it targets something called amyloid beta, which is a prevailing hypothesis in Alzheimer's disease, and it has had a couple of phase 3 trials, one that did well, and one that didn't do so well. So they have combined that data and they're doing what they can to package it in a way that the FDA will accept so that it can reach approval. So more about Alzheimer's, the disease space itself. So, as I mentioned, there's this drug called aducanumab, which targets amyloid beta. And amyloid beta is sort of the oldest, not oldest, but maybe the most known driver of disease pathology in Alzheimer's. And what happens in people with Alzheimer's is this small protein called amyloid beta gets released from cells in your brain and begins to aggregate and form these plaques, which you can see on a microscope, and it's sort of one of the ways that they diagnose Alzheimer's. And I liken it to trash that isn't picked up off your front porch. You put your trash out there. Normally, the trash man comes and picks it up, but for whatever reason, in Alzheimer's patients, it doesn't get picked up, and it just piles and piles up and piles up and piles up and gets these really heaping piles of garbage that ultimately degrade your neurons. And they degrade your neurons because amyloid beta itself is neurotoxic, but it can also, the aggregation can cause an immune response and kind of aggravate that part of the brain, and cause sort of like broadband destruction of your neurons, which can lead to the symptoms of dementia. So that's sort of the conventional hypothesis of what they think is happening with Alzheimer's. It isn't bulletproof. There are some tricky observations, like patients that have lots of A beta plaques but don't have as aggressive dementia, or the inverse. They don't have a lot of A beta plaques but they do have advanced dementia. A lot of anti amyloid beta molecules have failed. Aducanumab is a bit of a unicorn, and then it's made it this far. And I think because of the types of A beta monomers that are A beta aggregates that it binds to, and it binds to specific sort of intermediate sized fragments, not tiny pieces of garbage, not huge piles of garbage, but right in the middle to kind of clear it just as it's starting to reach an inflection point. But some people are still skeptical that it's going to work. And there's another protein that's relevant in the story called tau, spelled Tau, and it has a similar arc in the sense that it is also a smaller protein that gets hyperphosphorylated, and phosphorylation is like a post-market modification, like tinting your windows or putting rims on your car, but it gets overdone, and you get hyperphosphorylation of these tau proteins, and they begin to aggregate, kind of like mad cow disease, into these things called tau tangles, and they also think that that's driving the pathology in Alzheimer's. And so there are other monoclonal antibodies that are being used to target tau, similar to how amyloid beta is being targeted to kind of clear it and to sort of remove it from people, and ideally do something about the pathology of Alzheimer's, and ultimately make a positive effect on clinical symptoms. And that's sort of the 1A 1B of where the treatment space is for Alzheimer's, at least has been for like the last maybe 20 years. And I came across a different drug and a different way of looking at Alzheimer's, this Atuzaginstat cortexime approach that I thought was fascinating because it looked at Alzheimer's differently in a way that was complementary to what is known about the disease, but sort of opened new dimensions in how to investigate it. And so Atuzaginstat is a protease inhibitor, and it specifically targets things that are called gingipanes, which are proteases or enzymes that can chew up proteins. That's why they're called proteases, that are produced by a bacterium called Porphyromonas gingivalis, or P. gingivalis. And that's actually the same bacterium that causes periodontitis, or more commonly known as gingivitis. So that's sort of the arc of the Atuzaginstat story. So sort of to play it backwards, people, or the hypothesis that cortexime has is that people have this bacterium in their gums, and somehow it translocates to the brain. It likely acts as a stowaway in certain types of cells that can get into your bloodstream, cross your blood-brain barrier, and they can find their way into various nerve cells where they can do damage using these gingipanes. The gingipanes are used by the bacterium to eliminate cytokines and other signaling molecules that your immune system uses to identify pathogens. So it uses these gingipanes to hide from your immune system. And these gingipanes can also do damage to neural fibers, which may lead to the neurodegradation that causes Alzheimer's. And so it's an interesting hypothesis. It was driven most fundamentally by the fact that if they looked at brain slices of people with Alzheimer's, their autopsy slices, they found high levels of this bacterium. So meaning, wow, there's this bacteria showing up in these Alzheimer's patients. Exactly what it's doing and why it's doing it is maybe not certain, but it's there. Another interesting wrinkle is that there's some speculation that amyloid beta actually functions in an antimicrobial capacity, and it's actually an attempt by the body to fight off this bacterial infection. And so it's not necessarily looking at Alzheimer's in this sort of gingivitis bacteria lens doesn't necessarily box out or preclude any of the other amyloid beta or tau line of thinking. It actually supplements it, and it's conceivable that it complements the what we know about Alzheimer's and how we're going about it pretty well. And that I found to be the most exciting part, that it's not actually forcing us to chuck our progress, but rather to add to it and maybe fill in some gaps that sort of seemed impenetrable. So cortexime is sort of all full speed ahead with this drug. They did a phase 1 trial, which investigates kind of the general safety and tolerability of the drug. They usually do it in healthy volunteers. In cortexime's case, they did a study with just over 30 patients. Most were older, healthy individuals, and a handful were Alzheimer patients, just to get a sense of what it's going to do and to figure out how to dose it in a larger study. And the good news is that there wasn't a whole lot of news. The safety profile is very clean. The safety signals were pretty benign, which one would hope for targeting a bacterial enzyme rather than a sort of a normal human function. There were some modest clinical effects, which you can't really say much about with just over 30 patients. So it certainly didn't confirm that it's going to work, but it certainly lends initial momentum towards that effect. And so cortexime was optimistic enough to move on to a phase 2/3. So instead of doing a shorter phase 2 trial, smaller phase 2 trial, they just went right to a larger study that's going to have just under 600 patients. It's a 48-week trial called the GAIN study. And it's recruiting now. And ideally, the data will read out sometime next year. But it's an attempt to test this hypothesis. And I think that the aducanumab story is a good one. It's got, has had a lot of momentum behind it. There's a lot of eyeballs on it. It will likely find some semblance of approval. I can't imagine the FDA totally turning its back on aducanumab. It might take a while, but I imagine it will finally end up on the market, just because the unmet need is so enormous. And things like Atuzaginstat can supplement it and be a good add-on, and the beginnings of an Alzheimer treatment armamentarium, where we'll have multiple options to kind of attack this disease, because I don't think there's going to be a silver bullet for Alzheimer's. And ideally, with amyloid beta monoclonals coming up, there's also tau monoclonals treatment options coming up. You're beginning to see this, that you're going to have an assortment of options like we see with multiple sclerosis. And the reason why I bring up MS is that in doing my sort of first pass at this company, and I first came across them through their video, which I'll post in the show notes. It's awesome. That really kind of highlights in a brief way what I'd already told you about the bacterium itself, the gingivitis bacterium, the gingipanes, the protease, and how this all sort of functions. And I encourage you to take a look at it. It's cool. And that kind of summarizes it well. But what really kind of got me to sort of really believe in this is I was looking at their scientific advisory board members, and there's a gentleman by the name of Ted Yednock, who is somebody that I have a lot of admiration for, because he's the inventor of Tisabri, and TY for Tisabri is actually for Ted Yednock. So just sort of, he's very much a part of its DNA, that drug's DNA. And Tisabri is also another good drug. It's a tricky drug, but it's a good drug. And if he's involved in this, I think it's worth paying attention to. And so who knows what the clinical data for this is going to look like, but I find Atuzaginstat to be exciting, and it gives me hope and optimism for Alzheimer's. I think that as we find new ways of looking at diseases and just the body itself, we find new treatment strategies. And fortunately, in this case, they can complement what we already have, and we don't have to have a fatalistic viewpoint on some of these treatment approaches, and we'll slowly begin to build a foundation with which to treat this disease and hopefully do a lot of good out there. So I just wanted to use this first episode to highlight what I think is a good drug, and I hope to do more of these in the future. And stay tuned and take care. Be safe.